Welcome everyone. I'm Giuseppe Rosano from St. George's Hospital in London, and I'm thrilled to chair this webinar on improving heart function, transdisciplinary innovative drug and device solutions for heart failure care. And I'm pleased to introduce the team for today.
Hello, Giuseppe. I'm really happy to be here. I'm Alexandre Mebazaa from Paris. I'm intensivist and heart failure specialist.
Hi, Giuseppe. I'm Emanuele Barbato, interventional cardiologist from Rome in Italy. Very happy and delighted to be here today.
Hi, Giuseppe, and all of you. I'm Christophe Leclercq from France. I'm electrophysiologist. I'm very pleased to be part of this fantastic journey.
And we have another member of our team online. Please, Sabine.
Yes, hello from my side. Also, my name is Sabine Bleiziffer. I'm a cardiac surgeon in Bad Eindhausen, Germany, and very happy to be part of this webinar and initiative.
So as you can see, a very transdisciplinary team today with you to the launch of this new initiative, of which we will tell you a bit more later. But before telling you that, let's say how we all started. Emanuele, probably want to give us your views on how we started and your experience.
Yes, thank you, Giuseppe. Actually, it all started when we started to work together and collaborate at different projects. And I had the pleasure to attend one of your conferences when the same patient, the same clinical question was addressed from a different perspective, which was the perspective of the heart failure specialist. And being an interventional cardiologist myself was for me an eye-opener. I said, wow, these same patients I would have treated with stents, with valves, with clips. But that was for me an enriching experience. And I guess the same was for you at the same time.
Absolutely. And it was not just when I was attending meetings on interventionalists, but also when I went to the electrophysiology meetings or the preventative cardiology meetings, where I saw that there was a disconnect in care of patients, and where often we were losing this continuity of care on our patients, and there was a need to better integrate teaching and, of course, on the other side, learning, but also, and what is most important, the continuity of care for our patients. So let's ask our faculty, starting from Sabine, on their experience about and their history and interest in IHF.
Thank you, Giuseppe. So when I first heard of this initiative, I was really thrilled by the idea and concept, because heart failure involves maybe more than other diseases, many organ systems, and therefore affects many disciplines. And to put all these pieces of the puzzle together, we as specialists have to share our expertise. The IHF initiative is developing approaches to reach this goal, and this includes education in many different formats, like this webinar, community building, and raising awareness on the topic. So for me, personally, this is a great opportunity to help patients receive the full potential of treatments, as I am always committed to improving outcomes through a collaboratory, innovative heart team approach.
Alex.
Yeah, I really, for me, it's an initiative that is a little bit like a dream come true. In my daily practice, when the cases start to be complex, I love to have a heart team meeting where I'm learning a lot and where we put again the patient in the middle of the screen and we try to see how we can optimize this. We have many specialists coming when the patient is in the ICU during the acute phase, and I would love to see all those specialists following the patients when he's discharged from the ICU.
And Christophe.
For me, this initiative will fill the gap in my clinical practice, because I have, of course, an EP view for treating patients, and I realize that sometimes I did not offer the patient the best management. I can see also in my practice that some patients are not referred or referred too late for cardiac implantable electronic devices. So I think it's a huge opportunity to foster the collaboration between a subspecialty of cardiology, but beyond cardiology, pneumologists, nephrologists, and also our dedicated team of nurses and dietitians and so on.
Yes, so let's get started, shall we? So let's start with first of all, what the objective of this webinar. First of all, is to answer the unmet needs in healthcare patient management and to foster the collaboration between the different disciplines and heart failure stakeholders. Today, we have some of the heart failure of the cardiology subspecialties, but we will, in the next webinars, we will also expand to other specialties. But for today, is to foster the collaboration between the subspecialties stakeholders, to develop the relevant expertise in drug and device synergy. We'll see that from the two cases that will follow, how important is to have an expertise in managing the optimizations of the drugs and device, and also to cover the gaps on the educational models and connect the programs from different disciplines, with the aim to have our heart failure patients at the center of this transdisciplinary management that will involve the cardiologists, the different cardiologist subspecialties, but also the internists, the geriatricians, the general practitioners, the nephrologists, endocrinologists, the cardiac surgeons, the nurses, the pharmacists, and the intensivists, all of whom will have to concur for the holistic care of patients with heart failure and provide, what is most important, a continuity of care for our patients. So I'll ask you all of you to introduce yourself through the web chat that is provided. We are interested in learning what are your specialties, your setting of care, and also put as much information as possible into the chat box.
Yeah, Giuseppe, indeed, this is an interactive educational initiative. We want to learn from each other, really in a peer-to-peer exchange of experiences here. So please use this possibility to tell us what is your specialty. That's actually in the chat box, which is available. Most importantly, during the course of this hour together, we will share practical case example. There will be key questions posed to you. Feel free to contribute to these key questions when they are under the form of poll. Do not forget that to answer the poll, you have to log on our IHF website. There you will have the chance to answer this poll.
So let's get started with the first case. Please, Emanuele, crack on.
Thank you very much. Let's get to the first patient then. There we go. This is a patient we selected for our discussion today in the team. A male patient, 75-year-old, presenting to our observations in August 2022. Common cardiovascular risk factors, no relevant cardiovascular events in the past medical history. At the time of the first presentation, the patient had acute resting chest pain. Lab tests were unremarkable. The therapy at the time was mainly focused on the hypertension of this patient. He was taking valsartan. This is the ECG that tells it all about the problem of that patient. An acute ST elevation in the inferolateral leads. And as a matter of fact, the patient was then immediately transferred to the cath lab. But before looking into the coronary angiogram, this was the left ventricular function of these patients at the transthoracic echocardiogram, with still preserved left ventricular function, posterior wall hypokinesia, and mild mitral regurgitation, which is barely to be seen given the poor quality of this exam. At the coronary angiogram, the patient presented a mild mid-right coronary artery lesion. The problem, you see it in the middle, a subocclusion of the first obtuse marginal branch and a significant mid-LAD lesion. The treatment for this patient was a primary angioplasty of this first marginal branch with an implantation of a drug-eluting stent. Next, during the same hospitalization, a few days later, we completed the revascularization, bringing the patient back to the cath lab and implanting a stent into the mid-LAD. Further course of hospitalization was uneventful. The patient was stable. He was then discharged after 5 to 6 days from the admission. To the right, you see the transthoracic echocardiogram at the discharge. Overall, not much of changes as compared to the admission transthoracic echocardiogram. And let me spend just a few seconds on the therapy at the discharge. He was prescribed dual antiplatelet therapy, calcium antagonist, high-dose statins with atorvastatin, and a little bit of beta blocker, bisoprolol in this case, and a little bit of ramipril. And here it comes, the first question to the team and to the colleagues connected with us. This is an acute coronary syndrome patient presenting with multivessel disease. First of all, do you agree with the revascularization strategy we adopted, or would you have different option? Secondly, any thought about the pharmacological therapy that we prescribed at the discharge in this patient? And last point, which clinical follow-up would you undertake for these patients if you were the treating physician?
So whilst we wait for the answers on the web, then I may ask Sabine, your opinion regarding this patient. Would you have done anything different, especially for the revascularization?
Yeah. So surgery is often seen as the end of the road, but it can also be part of the lifetime journey if chosen timely. But in this case, it was an acute coronary syndrome, and of course, PCI is first-line therapy. In some patients, it might be an option to also consider bypass surgery in those cases where PCI is not an option for any reason. But I think in this patient, two-vessel disease formally now, because the RCA was not severe, and acute coronary syndrome, of course. So in our heart team discussion, we would have come to the same decision. I'm sure about that.
About the pharmacological therapy at discharge and the follow-up of this patient.
Yeah, thank you for this question, Giuseppe. Often we forget when patient comes in acute condition, we forget that we need to treat the acute event, but the acute event happened also. For me, I used to say to my fellows, the patient comes with a red flag to tell you that he's really having a chronic disease, and this acute event is just the beginning. At least he's expecting to have a treatment for a long journey. And it's true that for this patient, this episode is really a red flag, and we really should not hesitate to be rather aggressive in the therapies before discharge, see the patient often after discharge, because not only we need to prescribe medications, but we need also to have the patient understanding his condition and also accepting and adhering to those chronic medications.
Giuseppe, I've got a question here, actually more than one, but perhaps we can take the most relevant at this point. Any chance to administer a PCSK9 inhibitor to this patient already at the admission for the acute episode?
I think it very much depends on the practice of your setting, because in some countries you can start with a PCSK9 inhibitor. In other countries, you need to have patients fully optimized on statins and ezetimibe before starting. And I believe in most European countries that is the case. Yes.
I think for this point, it's very important to stress the fact that this patient was successfully treated by STEM, but the story is not ended for this patient. And I think this patient should have a very, very close follow-up about statin and LDL cholesterol dose. And I think it's something that we have to keep in mind, that this patient should also receive education, and also probably cardiac rehabilitation could be a good option for this patient.
Absolutely.
Perhaps another question, maybe for me, it's about the revascularization strategy, the percutaneous revascularization strategy. This colleague from India is asking about doing invasive physiology to guide the revascularization of the other two vessels. Well, we tend to do that in our practice, especially in this kind of patients where the clinical presentation is, from an hemodynamic point of view, stable. And we tend to do it, if possible, ad hoc, right after having treated the culprit vessel, to measure the other two, and if they are significant to FFR, then to stent it. But for this particular patient, we brought the patient back a few days later, and the lesion on the LAD was tight, actually. It wasn't clear on this angiographic view, so it didn't really need additional invasive evaluation, but this is certainly an important point.
Okay, let's just continue with the case just for sake of time.
Sure. So, unfortunately, we lost from our radar screen this patient. We didn't follow him up well in our outpatient clinic. And as a matter of fact, after a little bit more than 1 year, in September 2023, this patient presented again in a spoke hospital, this time with acute resting dyspnea. And I show you immediately the chest X-ray of this patient that speaks by itself. He presented with pulmonary edema, as a matter of fact, no significant ischemic EKG changes. Lab tests were also telling this patient had little troponin elevation, but a significant NT-proBNP elevation, more than 3,000. And as it was already anticipated by Alex and Christophe, an LDL cholesterol that was far from being at the target. This is actually the transthoracic echocardiography of these patients that after 1 year looks pretty different from the one, if you recall, at the discharge. Well, first, the global ejection fraction was moderately reduced this time, but most interestingly, mitral regurg worsened. Now we speak about at least moderate mitral regurgitation. How was this patient treated in this spoke hospital? With intravenous diuretic, it was stabilized and discharged home at day 7. This was the medical therapy. In yellow, you see the medications that were changed at the occasion of this admission. So bisoprolol was changed with metoprolol, 50 milligram twice a day. ACE inhibitor were increased. Ramipril was brought to 5 milligram. Ezetimibe was included now. We have a mineral corticoid added to the therapy and ivabradine. The patient was then referred to our heart failure clinic. He presented at our place a couple of months later. This was the lab test of the patient, and these were the therapy that we fine-tuned at our outpatient clinic. So back to bisoprolol, Carenon, dapagliflozin was included, Entresto, and furosemide. That's the echocardiogram that is just 3 months after the pulmonary edema. The mitral regurg at our echocardiogram was much more pronounced. And this actually prompted within the heart team the indication to TEER for this valve. These are just few key images for the TEER and the result that you see on the mitral regurg. And here it comes to the second crossroad, points of discussion for you. First of all, do you agree with the heart failure management of this patient? Is there any room for additional device-based therapy beyond the mitral clip? Giuseppe.
Yes, let's discuss whether it is important at this point to start a PCSK9 inhibitor. Alex?
Yeah, I mean, again, I think you said it very well before. In many countries, you should first start and then have the inhibitors coming later. I see also there is a question on heart failure management. In the spoke center, clearly they were a little bit behind. I think we can all agree. The patient came with 3,000, I think, of NT-proBNP, which again, it's a red flag telling everybody, I'm sick, my heart is sick. And he should have left clearly with maybe more aggressive medications, maybe a transfer to a heart failure center, maybe as quickly as possible to start medications. And probably would have seen maybe a better improvement. We will discuss later about the mitral regurgitation, but now there are data showing that if you give the 4 pillars at an optimal dose, you can see even the mitral regurgitation being reduced. You see even the size of the left ventricle being reduced. And then the indication, which at the end of the day would have been TEER anyway. But it's interesting to say, first, let's optimize and then put the TEER. But again, bravo for this case, because it's really an exciting case.
Okay, so
perhaps we can take this question from our colleague. Why was valsartan replaced by ramipril? Well, in our case, it's simply because we like to use ACE inhibitor in this patient, but is there any different preference here?
I think the recommendations are at least clear that there is no difference. Now, if you try to see recommendations from different continents, the US and Europe, and data that are appearing, probably more and more people are switching quickly to Entresto. But between antagonist of angiotensin II and ACE, the difference in heart failure is really does not exist.
Yes, and any space for any EP management of these patients?
So far, I would say no, but I think as this patient will be treated by TEER and had the other left ventricular ejection fraction about 40%, I think I will be very cautious to assess the evaluation of the left ventricular ejection fraction, because we can assume that the left ventricular ejection fraction will decrease a little bit after. So I will be very keen to follow very closely this patient and not to miss the indication for ICD if the ejection fraction is below 35% in this ischemic patient.
So, Emanuele, please continue.
Yes, Giuseppe. Unfortunately, the story with this patient goes on. It's not yet over because 3 months later, these patients presented again with acute chest pain. So that is a symptom that we are simply not doing very well here. Lab test, more robust increase in troponin as compared to the previous lab tests we have seen so far. NT-proBNP definitely better this time. And LDL cholesterol, despite atorvastatin, despite ezetimibe, still far from being at the target. ECG this time showed an ST segment depression in V3, V4, Q waves in AVL. And this is the echocardiogram of this patient. I don't have a color Doppler here, but the mitral regurg was fine at this moment. That's the ejection fraction that we assessed at that moment. We brought the patient to the cath lab, and guess what? We found an occlusive in-stent stenosis of the marginal branch in this patient. The stenting to the LAD was fine, so we treated with drug-eluting balloon the marginal branch. There was a clear progression in the stenosis of the RCA that this time was treated with a drug-eluting stent implantation. So at the end, the patient was discharged after a few days in a stable condition. He's still now closely followed up. We are not repeating the same mistake again. So we are hearing on a regular basis and seeing on a regular basis this patient. And finally, we got also a PCSK9 inhibitor in the long list of medications that this patient is taking.
Thank you. I mean, this case depicts very well two important things. The first one is this silos approach within the subspecialties, and the fact that often patients are treated for what it seems to be the culprit lesion or condition at that moment, and then is left out in the field where the heart failure is picked up later. But the other important point, and I think you did very, very well on that, is the fact that you thought out of the box and you looked at that patient with that had a left ventricular function 40-45%, so as mildly reduced, and you implemented the full medical therapy for reduced ejection fraction, therefore focusing on the trajectory of that patient. That patient, if would have been intercepted later, probably you would have seen it with 35% of left ventricular ejection fraction, or even less if they had an event. So in intercepting this reduction in left ventricular function is important because you can treat early and recover. So that is another silos approach that we have to break. So the fact that we don't have to look at reduced, preserved, or mildly reduced, but rather to see how patients are evolving throughout that case. But I don't know whether we have other questions on from the...
There are several, but many of those, if not all, were already addressed by the comments that were given before. So we are doing quite fine for the time.
Yes. Anything to add, Christophe?
No, I think it's a very good example of the transdisciplinary approach, and also the necessity of the close follow-up for this patient. And I think that we are interventional cardiologists, and I think that it's very important not to think that after the implantation of the stent, the story is over. But we have to be sure that the patient will be followed by the right physician.
Yes. And also, it highlights the importance of an early and aggressive lipid-lowering therapy because, as we've seen for the right coronary arteries, that within a few years, there's been a progression of disease. So just to wrap up this case, I think this highlights the fact that this patient was an acute coronary syndrome initially, a patient that was treated mostly with intervention, where pharmacological therapy has been implemented lately, but fortunately, while intercepting the progression of the disease in these patients. And of course, there is the issue of the follow-up that probably could have been a little bit better in terms of being more timely. And of course, that depends on the different cares and the different transfer of care in different countries. So I think we can move on to the second presentation. Please, Christophe.
Yeah, thank you very much. So I just want to present you the story of a young lady. She has no medical history, no medication. The only abnormality was that this patient had a lot of sport activity, and she had a cardiac check many years ago. And on the ECG, there was a left bundle branch block. She got at this time an echocardiography with a mildly reduced left ventricular ejection fraction around 45%. She has also some risk factors. She has dyslipidemia, and also, despite her sport activity, she's an occasional smoker. So as I told you, she's very active. She's swimming or jogging several times during the week. But she complained during the last week she felt less comfortable during the exercise. And I received this lady during one night when I was on call for an acute heart failure with acute pulmonary edema. After stabilization of the patient, especially with nitrate and intravenous diuretics, this is our ECG, and I think that all of you agree that this ECG is in sinus rhythm, but with very wide QRS related to a left bundle branch block. And we perform also, after stabilization, an echocardiography, and I think that all of you will agree that this echo is not normal. There is a decrease in left ventricular ejection fraction, and if you look at the apex, we have apical rocking related to dysynchrony due to the left bundle branch block. So the first question I have for you and all the audience is, after the stabilization of acute heart failure, would you need another imaging evaluation beyond the echocardiography? And so first you think that you have done with the echo. Second one, you need an extra evaluation with CRM. Number 3, with a cardiac CT. Number 4, coronary angiography. Number 5, CRM plus cardiac CT. And finally, number 6, CRM plus coronary angiography. And I will be very happy to know what you think about this imaging strategy.
I mean, given that this young lady, I mean, she's in early 50s and has some risk factors, but yet at that age, probably the penetrance is less. I would go for a CMR first, and then eventually for a CT, coronary angiogram. Also because there is the need to exclude a myocarditis or something that could have happened and that could have precipitated the condition as well as the left ventricular function. But I don't know, probably my colleagues will have a different approach.
So by the way, the debate is flying up here. People is heavily interfering. But before disclosing the poll, I'll tell you this silos approach that is permeating my practice. I would first of all exclude obstructive coronary artery disease in this young lady. After all, she has cardiovascular risk factors. She's been also occasionally smoking, a left bundle branch block, and she has an additional risk factor. Let's not forget that she's a female. And by definition, those are most of the times underdiagnosed patients. So That's why I would keep the bar pretty low and try to, first of all, do a cardiac CT. 50 years old, I do expect a good diagnostic accuracy from cardiac CT. And also because cardiac magnetic resonance is not readily available on a daily basis in my practice. If on the cardiac CT there would be no sign of obstructive disease, I would definitely go for CRM.
What about you?
Yeah, I would do the same. First, maybe we should really remind ourselves and all the listeners that there are more and more young patients coming with acute heart failure in all our departments. I mean, the data are clear. We don't know why, but there are more and more young patients. And we should not underestimate that those patients need exactly the same recommendations than a patient 20 years older, and this is often a mistake we would do. Then I would have the same strategy. I would go straight. We are lucky CRM and cardiac CT are rather easy in our institution. We would go straight for the two to make sure to understand what's happening here.
Yes, Sabine, what about yourself? What would probably this is not a typical patient you see immediately, but what is the approach in your center?
You're right. This is, of course, not a patient who would be referred to surgery first. But, of course, for me as a surgeon, the main question is there a structural problem? And therefore, I also think for the reasons you have mentioned, because of her risk factors, that an angiography might have been performed at my center.
Yes. Emanuele, I don't know whether we have questions.
Yeah, I was just smiling with Christophe, having a look at the poll. Do you think it is the moment to disclose the poll?
Absolutely.
So 63% of our colleagues propose to have, if I can have the poll again here. It took it away too quickly. But I think at the first place, there we go. We have at the first place CRM and coronary angiogram, 63%. Then coronary angiography, 25%. Echocardiography is enough, 13%, and CRM and cardiac CT, 13%.
Oh, that's very, very interesting. So let's see what you've done.
In fact, we did, as the majority of the audience, CRM and coronary angiography. But I agree with Alexandre and Emanuele that a CT could be a very good option. She's a young lady, probably with not too much calcification. I think the fact that the majority of the attendees selected coronary angiography could be related by the fact that in some centers it's not very easy for cardiologists to have access to cardiac CT. But I think that for this lady, in terms of, I would say, safety, cardiac CT will be the first option because we can, as we know, have coronary dissection during diagnostic coronary angiography. Okay, so we move on for these cases. So this is just what we did. So as you can see, there is no significant stenosis on the coronary arteries. And if you look at the CRM, the left ventricular ejection fraction was quite low, 21%. And I would say, thankfully for this lady, she didn't have a significant fibrosis. So the next question now, I think we have to discuss this, is about the management therapy after the stabilization of the acute heart failure. So I have several proposals. The first one is that you start with beta blockers and RICE inhibitors. Number two, above beta blockers and RICE inhibitor, you had mineraloreceptor antagonist. Number three, on top of the three previous one, you had the SGLT2 inhibitors, as we call the four fantastics. Or you are a very active EP and you want to implant CRT right away without any optimization of any medical treatment. So you have still 30 seconds to vote and to let us know what will be your strategy about that.
I think I would first of all start on the 4 pillars and wait 3 months in order to decide what happens, especially for the indication for the CRT. Alex?
Yeah, Giuseppe, you're right. I mean, she's young, she has no kidney dysfunction. no therapies before, then she should handle very, very well, not only a rapid, but also an intensive implementation of those 4 drugs. We know that within 2 to 4 weeks, she can be really on the optimal dose. Probably we need to do it here in this case, although we did not understand fully why there is this myocardial dysfunction. But probably we need to start exactly like you said, at least to understand where we are going to see how the heart is going to react on those 4 pillars at the highest dose. Is she going to cope with the highest dose? Is she going to do bradycardia maybe with a mild dose? Then we need really to start an intensive strategy to understand how she's going to react, and we hope for her benefits. Yeah.
I think you're curious to know what our colleagues have answered. Well, first of all, no one would consider CRT at this stage, just to reassure Christophe.
I'm happy.
But 80% of our colleagues would go for the 4 pillars, while 20% would go for beta blocker, RAS inhibitors, and mineralocorticoid inhibitors, like aldosterone and others.
Yeah, I don't know why. I mean, the SGLT2 inhibitors remain the Cinderella, and then you always think of them at the end. Whilst they are very safe drugs to use, I mean, they further enable the use of ARNI, ACE inhibitors, and MRAs. So I think, and also they don't have any hemodynamic effect. I mean, the effect on blood pressure is minimal. So I think we should start the practice as Alex has shown us in the strong HF. I mean, start all of them together and then up titrate gradually. So let's see what happens.
So I'm very anxious about what we've done. But we did that. It was recommended in the last heart failure recommendation in 2023. We started the 4 drugs. If I may make a comment, the problem is not to start the 4 drugs. The issue is to be sure that the 4 drugs will be uptitrated in a reasonable time, I would say 4 to 6 weeks. And this is a big challenge because you mentioned previously, Giuseppe, that, okay, I start the drugs and I look after 3 months, but in clinical practice, the majority of the patients are not optimized for the medical treatment. They have the same treatment as they have at the discharge at 3 months. So I think that with the transdisciplinary approach, including the nurses, I think it's very important for us today to be sure that the patient will have the optimal treatment in the shorter time. This is very, very important. Okay, so of course you have drugs, but for this lady, I think it was very important to give her some advice about the lifestyle. So of course we have to help the lady to stop smoking. We have to give statins. We discussed with this young lady with a very, very low ejection fraction, 21% at the CMR, remind you, a live vest, wearable cardioverter, defibrillator, and also for this very young lady, we ensure to have a very close follow-up to optimize the drugs. And we decided to make a new echocardiography at 3 months. So what was the status at 3 months? She has bisoprolol, say 7.5 milligram per day. This was related to the fact that she had a bradycardia around 45, 50. She has sacubitril, valsartan as the optimal dose, eprerenone, and empagliflozin. As you can see, the blood pressure was correct. She has no sign of heart failure decompensation, but she was still complaining she cannot exercise again. When she walks, she had fatigue. And so the echocardiography did show an improvement as compared to 3 months before, but it was a still depressed left ventricular ejection fraction, 33%, with a large ventricle. So for this lady with what we consider as optimal medical treatment with very wide QRS, left bundle branch block, still a poor left ventricular ejection fraction, of course we decided to implant a device for cardio-resynchronization therapy. And even if this lady has no ischemic disease, but she's a young lady, we decided to implant a CRTD, so a defibrillator, to protect her against sudden cardiac arrest related to ventricular fibrillation. So at 6 months follow-up, she is still symptomatic with fatigue when she was exercising. On the ECG, the electrical result is pretty nice with a narrowing of the QRS as compared to the baseline ECG with left bundle branch block. The electrical parameters of the device are perfect, so the device is working perfectly. But I didn't understand why this lady was still symptomatic, because when you look at the echocardiography, you see that the echo is almost normal. She has a good left ventricular ejection fraction, or 55. There was no sign of diastolic dysfunction, but this lady was still symptomatic. So I didn't understand very well, to be honest. So I asked my colleague for the Heart Failure Clinic their advice, and they told me, I think you have to perform to this lady a cardiopulmonary exercise test to have an objective view of what's happened when she's exercising. And you may appreciate on this slide that the baseline heart rate was 55, which is normal for a lady with beta blockers. But when you look at the peak exercise, the workload was very low, only 80 watts. For a young lady with a jogger, 50, it's very, very low. And this was related to the fact that we have an atrial chronotropic incompetence, because the maximal heart rate was only 65 BPM at the peak of the exercise. So thankfully, with the device now, we can switch on the rate algorithm, and after this new tune of the CRTD, the heart rate was almost normal, 155 BPM. But look at the workload, we increased from 80 to 170 watts. So I think this was a good example of the collaboration we have to have all together when we follow patients with heart failure.
Yes. And
just to finish, a very important message. If you look at this graph, you have the patient in green. They have an indication for CRT, but they did not receive the CRT. And you can see that only 30% of the patients with a strong indication for CRT receive a CRT. So there is a huge underutilization of the device in this population. So I think that a close collaboration between all the stakeholders of heart failure will help to improve this very bad result.
Thank you, Christophe. Do you think that this data are more related to, say, a lack of referral rather than problems of in implantation?
Yeah, I fully agree with you, because when you refer a patient to an EP center, usually they have the device. Because I don't think the problem is the implantation of the device. The problem is the referral of the patient to the electrophysiologist, definitively. Because sometimes our colleagues don't think about cardiac implantable electronic devices. So I think that we have still to make a huge education of the physician. And this was the program is very useful, I think, just about all the strategy we can have for our heart failure patients.
Yes, and I think this data from the Swedish heart failure registry also probably actually overestimate the referrals, because these come from specialized heart failure centers. So if we look at all patients that we are missing in primary care, in general cardiology, even before they come to the heart failure units, that probably is even, the unmet need is even bigger.
Yeah, I fully agree with that. So probably the real life is worse.
Yeah. Now, regarding your approach of putting the rate responsive device, when you do use the rate responsive, would you also reduce your beta blockers, or keep the beta blockers?
No, I keep the beta blocker at the same dose, and even I can increase the dose of beta blockers, because for this patient there was a limitation to target the optimal dose because she has already a bradycardia. So I think it's important. Your comment is very important, because in some patients we have a synergy between device and drugs, and with the device we can optimize the medical treatment. Sometimes you have some limitation due to low blood pressure or heart rate. And with the CRT, for example, you increase the blood pressure, you increase the heart rate, and you can optimize the medical treatment. So there is a synergy between drugs and device. It's not a competition, it's a synergy.
No, absolutely. But sometimes, I mean, we see patients that complain of main fatigue. In that case, we try to reduce the beta blockers first thing, and maybe use beta blockers and ivabradine in order to reduce the fatigue. I don't know whether that is shared. So I think we can wrap up this case, and we can, unless we have a few questions.
Yes, actually, we've got a few questions. Certainly the first one is for you, Christophe. But from my perspective, who know very little about all these electrophysiology devices, a colleague is asking CRT-P more than CRT-D. So first of all, for those not familiar with P and D, explain the difference and when using what.
Yeah, CRT-P means pacemaker with synchronization therapy, and CRT-D means defibrillator with synchronization therapy. I think this question is very, very good, and it's difficult to answer. Because, of course, this lady is young, and you know that in the Danish trial, there was a little bit a thunderstorm for the EP community, because in patients with non-ischemic cardiomyopathy, there was no impact of CRT-D over CRT-P to improve total mortality. There was an impact on sudden cardiac death with a reduction of 50%, but not on global mortality. And the subgroup analysis did show that in patients less than 68 years old, you have a benefit of CRT-D. So, but I agree with our colleagues, because this patient, she has a long story of LBBB, and probably the dysfunction was related to LDDD only, because we have no coronary artery disease. And what we have seen as well, that was we have a huge improvement in the left ventricular ejection fraction. So I agree that CRT-P in this patient could be also a good option. It's always a case-to-base, but the left ventricular ejection fraction was so low at the beginning that we want to protect the lady. But very good question.
Giuseppe, I have another question, perhaps. This is more for Christophe. There is one colleague who's asking actually a common questions to both cases. What is the optimal follow-up for these patients? How frequent should the follow-up be? And most of it, do we have guidance for the follow-up?
Again, I think we had a very, very good listener here, a very top expert. Many times we heard the three of you saying follow-up of the patients, because I think now it's clear that the follow-up is important. In fact, what maybe we should say even a personalized follow-up. What I mean by that? I mean by that the patients with a chronic heart failure that is fully treated, this patient is stable. We don't have to see them before maybe 9 months, a year or so. Here, the two cases are really unique cases because they come with an acute condition. Then again, red flag, I'm not doing very well. Then those patients clearly should be seen very frequently in the beginning, and when they are stabilized, when the treatment is optimal, we can really reduce the level of visits. In patients coming out from an acute heart failure episode, what is recommended today is to see them every 2 weeks in the beginning, and we should have a maximum of visits in the first 6 weeks. In the US, they said in the first 3 months. In Europe, we say in the first 6 weeks. But the idea is what? The idea is we saw that if we have an intensive starting of the 4 drugs, we can see within the first weeks, we can see an improvement in ejection fraction, improvement in the quality of life, an improvement in dyspnea. Then it's not only increasing drugs without any effect on the patient. The patient himself, they say, oh, it's totally different from what I had before. Here, I see that I feel better. Then really, in the first 3 months, they should be seen very frequently, maybe the 2 first weeks in the first month, and then we have a little bit longer period between the visits, but really in the first 3 months, we should optimize. After 3 months, the patient likely will have a very good therapy, and then we can delay. Now, in your 2 cases, we see, interestingly, that despite the optimization, the patient is still fatigued. But if you optimize, then you immediately see that the patient has a problem. He should not be fatigued. And then you open the second drawer. Then it's important to intensify follow-up, to treat quickly the patient, but also to see if the patient is not taking the natural history.
Perhaps another one. I don't know if Giuseppe wants to contribute. We discussed about upgrading here, upgrading the drugs, upgrading the device. But one colleague is also asking, is there any room for downgrading, for taking off some of the measures, or are we only going up?
I think that once we have a patient that has demonstrated a reduction in ejection fraction and worsening, and then improves with therapy, that therapy should stay. Because it's, that patient is a very vulnerable patient. Because even if they recover completely the left ventricular function, even if that has been after an episode of myocarditis, then those patients will need to be on full medical therapy because another injury, another precipitating factor will bring their left ventricular function down. So it is important that once patients are optimized, they are kept on medical therapy. And Alex probably would like to comment on the fact that we need to get in these patients a dry NT-proBNP to follow them up.
Exactly, to make sure that they're really treated. And this question is really interesting because the two questions that we often have is when the patient goes, let's say, from 30 to 50% of ejection fraction, the two questions I often have is first, should I treat him now as a HFpEF? No, he was a HFrEF. You keep the same treatment for forever. And then the second question is, as Giuseppe is saying, okay, maybe now I can stop because it's 50%. Unfortunately, today, all the studies showed if you stop, the patient is going to come back and often in the bad condition.
So I think we can move and see, I mean, these two cases have clearly demonstrated the need for a transdisciplinary approach. I would like to hear from you four, I mean, your views on the need of this novel approach to heart failure. I would probably start with Sabine first.
Thanks, Giuseppe. I think these were both great cases to understand how this transdisciplinary approach can improve patient outcomes. I learned a lot, especially in the second case, because this is out of my scope, that there are so many options to improve patients' quality of life. And so I think we have learned that we have to think more out of the box, and surgery is an option, can be considered at some points of patients' lifetime journey, although it was not in these cases first-line therapy.
Christophe.
No, I think that the two cases demonstrated clearly that we have to work all together for the best of our patients, because by definition, when you are a subspecialist, you see the patient with some view and you forget perhaps there is other options. So I think that this initiative for me is very important to fill the gap of the working in silo, as you mentioned in the introduction, for the heart failure patient, because the heart failure disease is a transversal disease. And this involves all cardiologies, but we already mentioned before, so beyond cardiology. We have always contact with nephrologists because our patient has heart failure, but also kidney disease. So I think that it's very important that we consider the transdisciplinary approach as, I would say, a gold standard for the management of heart failure today.
Alex.
Very few to add, because I think really my dream come true would be that the cases that we treat in our centers, we are lucky to have heart team, we are lucky to have different disciplines, and we are lucky to learn a lot. I mean, even if we are really top expert in some area, and if we can translate this in IHF and have this seminar and many other webinars coming where we can learn so much, I'm sure it will be really a dream come true.
And Emanuele, I think you should be very pleased of this first step of the IHF initiative.
I am actually along the same line. It's a dream coming true, as was nicely said by Alex. I'd like to bring in another factor here. We discussed about cross-sectional approach or transdisciplinary approach. So bringing in lots of important stakeholders within cardiology and beyond cardiology around the patient who is at the center. But another important aspect is a longitudinal approach. This is what IHF is about. The longitudinal approach means taking in charge, prise en charge, they say in French, the patient for the whole journey, from the first clinical presentation and all the way down, involving all the key figures, like an orchestra, everyone playing his own instrument, but all of us making a beautiful melody that will bring up to the improved patient outcome, which is the ultimate goal of all of us here.
Yeah, and I think we all agree that we need to have a patient-centered approach with all the different specialists, all the different healthcare physicians and healthcare practitioners concurring in the care of our patients. So heart failure is not just the property of one subspecialty or the other. It's not just for the heart failure specialist. It's not just for the, say, the structural heart disease interventionalists when there is mitral regurgitation. There's not just for the EP specialists when there is a need of CRT or combined with POD. But we should involve all actors that take care of patients with heart failure. We have to consider that 70% of patients with heart failure are seen outside the heart failure units, are seen in general medicine, are seen in geriatrics, are seen in primary care. So it's what you, Emanuele, were saying earlier, the continuity of care, and also with the other specialists. Thus, we need to highlight the presence of other diseases and call in the nephrologist or the respiratory physicians. We also need to make them aware that very often they see patients with early sign of heart failure. So it's important to have this cross-fertilization. So I wish to thank the audience for being with us today. And thanks for watching us. Please follow us on LinkedIn, on X, on Facebook, and on our web page at any time. Before closing, I leave it to Alex that will tell us what is next.
Yeah, thank you very much. I guess everybody is happy with this webinar. Everybody is saying, and we heard it from the questions, that people liked the way we manage those patients. We learned that giving medications alone is not enough. Interventional cardiology alone is not enough. I mean, we understood very well in the two cases that not only we need to combine the two, but we need also to explain step by step to the patients why we are doing this and how we are going to follow those patients in the days and weeks following the interventions. The next webinar, the title is on novel fast-track strategies to guideline-directed medical therapies optimization in heart failure patients with functional mitral regurgitation. This webinar will be in June, and we hope to have you, all of you with us.
Thank you all.
Bye-bye.